Welcome everyone, and thank you for joining for today's webinar. My name is Lucy. I'm a TB Diagnostics Coordinator at ASLM. We are grateful to the Gates Foundation for funding this ECHO sessions. So today's ECHO session is organized in collaboration with Roche, and it focuses on how we can strategically implement and integrate molecular diagnostic tools for TB to improve diagnosis and patient outcomes. Each year, an estimated 3 million individuals with TB are neither diagnosed or treated. A key driver of this gap is the underuse of rapid molecular tools that are recommended by WHO. Therefore, in this session, we are going to spotlight South Africa. We're going to share their tiered model of mixed diagnostics that to provide us with practical and actionable insights that can help us to close this diagnostic gap and improve outcomes of people with TB. So before I introduce our stellar panelists, I would like to remind us of a few housekeeping items. This session is being recorded and will be for 1 hour. We'll start with the presentations from our two panelists, and this will be followed by about 10 to 15 minutes of discussion. You can join this discussion by posting your questions in the Q&A box. We also have language interpretation available in French and Portuguese. And if you can click on the globe icon on your Zoom toolbar, you can select whether you want to be in French or in Portuguese, or otherwise remain in the English channel. You will also receive the session slides and a recording of this webinar, as well as a link to download your certificate should you wish to. So now it gives me absolute pleasure to introduce our first speaker for today. And she's probably no stranger to most of us, but I'm really delighted that Dr. Patricia Ho-Aitson accepted our invitation to give us an overview of the policy guidance from the WHO. Patricia currently leads the newly established HIV, TB, hepatitis, and STI testing and diagnostics team at the WHO, really leading the way forward in integration. So welcome, Doc, and over to you.
Excellent. So thanks to ASLM for the invitation to be here with you today and to speak about our WHO guidance and resources for TB diagnostic selection and network design. So first, I'd like to focus on our overall recommendations. WHO focuses on recommending universal access to needed tuberculosis testing services. And these are included in the pillars of the NTB strategy and in the Implementing the NTB Strategy Essentials document that can be found linked here, where specifically all people with presumed TB should be tested for TB disease. All people with confirmed TB disease should be tested for resistance to TB drugs, at a minimum for rifampicin resistance as the first line and most effective anti-TB medicine that we have, with molecular WHO rapid diagnostics in order to inform appropriate treatment selection and start, and that all people at increased risk of developing TB should be tested for TB infection. However, despite these long-standing recommendations from WHO, our global data continue to highlight gaps in access to TB diagnostic services. In our most recent Global TB report that was published in 2024, the data from the year 2023 highlighted that approximately a quarter of the world had been infected with TB. There were approximately 10.8 million new cases, including approximately 400,000 with drug-resistant TB. And TB, again, was the leading cause of a single infectious agent mortality globally at 1.25 million deaths. However, among those 2.8 million incident cases, only a little over 8.2 million were notified to WHO by WHO member states, suggesting we're missing approximately 2.7 million people in this single year. Among those notified, so these that had program access and became TB cases incidentally within the programs, only approximately 48% received WHO initial rapid diagnostic testing. So this is approximately 4.2 million people that had access to the health system and were detected by programs, but did not receive WHO recommended diagnostic testing. A large proportion of this could be due to continued use of smear microscopy. And then of those that were tested with WHO recommended diagnostic tests, approximately 79% of those were tested. Now, this is a higher proportion overall, and largely due to the introduction of molecular tests that have combined rifampicin resistance detection with the tests. However, it does signal that still over 515,000 individuals globally did not receive this testing to ensure that their treatment would be efficacious. To address this, we released a WHO standard on universal access to rapid TB diagnostics. For members of the LabCoP community, this will be familiar as there is an ASLM initiative around this tool. It includes 4 steps across the diagnostic cascade from identifying people with presumptive TB all the way through to receiving a diagnosis, and 12 benchmarks below, including the use and access to different types of WHO recommended diagnostics across the cascade, including chest X-ray, WRDs for diagnosis of TB disease in primary healthcare settings, the availability of algorithms, diagnostic coverage, how patients with presumptive TB were tested and received their result in order to guide treatment, for example. And so to this point, I've been saying WRD, WHO recommended rapid diagnostic, and MWRD, the molecular diagnostics. And I just want to highlight that at this time, WHO has moved away from product-specific recommendations, and instead we provide recommendations and policy on classes of TB diagnostics. These are groups of diagnostics that share the similar characteristics around their purpose for use, their complexity, their infrastructure requirements, whether or not they're manual or automated, and their reporting method. And so what I'm showing here is the 10 classes that are currently recommended, grouped by purpose. These are the initial tests for diagnosis with drug resistance detection, initial tests without diagnostic drug resistance detection, the follow-on tests for detection of TB drug resistance, and tests for TB infection, for which you can see multiple classes shown on the left and products within those classes shown on the right. The top 2 tiers here, the top 2 groups that are shown now highlighted in orange, will be partially covered today by my co-presenter, Dr. Puleng in South Africa. So these include the low complexity automated nucleic acid amplification tests that many are familiar with, such as the Expert MTB-RIF Ultra assay or the TrueNat MTB Plus assay, as well as the conditionally recommended moderate complexity automated nucleic acid amplification tests, or NATs, for detection of TB and resistance to rifampicin and isoniazid, so additional resistance detection in the reflex tests across a range of manufacturer products, as well as then reflex or follow-on tests for resistance, including the Expert MTB XDR assay, for example. And so when we start to look at this list, programs are faced with choices, and this is a good thing for TB market diversification and for options of different tests that have different characteristics and therefore can meet different needs. And so this is where I'd like to shift from our guidelines into the resource section of the presentation. We do have a WHO GLI manual for selection of molecular WHO recommended rapid diagnostics, and it guides programs and stakeholders through 3 steps highlighted in this figure that's included in the document. Through the collection of data for diagnostic network assessment in order to assess the capabilities and the needs of the network and the program. This is everything from the national level down to the site level. The second step is to analyze that collected data, and the third is to use those outputs to inform MWRD selection, particularly for the diagnosis of TB. And then we have 4 pillars across here, where data is collected on national strategic plan guidance and policy documents, national TB and DRTB epidemiological records, national and subnational records and master lists for testing sample referral networks, and lastly, testing site infrastructure, again, covering each tier of the system from the program national level all the way down. In the second step, these characteristics from each of these data sources is analyzed, In the third, the outputs are used in order to estimate the testing demand at the sites, availability of sample referral linkages, and to see which identified MWRD capacities would be required to meet the patient and the program needs, and which sites are suitable for their placement. I also just want to highlight a second figure that's within this document and supported by the text narrative that looks at network and site level data guide. So this is where per site, a specimen collection site is assessed for whether or not it has an efficient specimen referral system. If it does, it can be considered an MWRD site directly. If it does not, then should this be established, or is there some kind of linkage that would need to be set from the referring clinic? And then for the MWRT testing sites, in order to determine the best selection or potential selection out of a group, we look first at whether or not that site needs to only detect TB and RIF-resistant TB, or RIF resistance and additional resistance profiles for rifampicin and other drugs. And this is guided by the epidemiology and historic testing data and the expected epidemiology within the setting of the site. Then the facilities are determined whether or not they're suitable for low complexity or moderate complexity testing. And this is also really important as a measure because these technologies, as will be highlighted by South Africa, have very different considerations for the size of the instruments, the weight of the instruments, the types of molecular spaces or the complexity that's required, air conditioning needs. And so those all have to be taken into account. And then lastly, within each detection category and under the complexity level for facility suitability, we have the list of the different recommended products. And so this helps to narrow down the list, and then programs can look more specifically at the different product considerations in order to make a final selection. In addition to that, I'm pleased to highlight that GLI and FIND just published a stepwise guide to diagnostic network optimization that also complements this manual by providing very specific steps, data collection instructions, linking to tools, and looking at different analysis options across a variety of different access considerations. So whether programs want to increase access, if they're looking to integrate test types, as Lucy highlighted, this is a priority and something that's happening at WHO right now. If you want to add or relocate devices, or if you're looking for on-site and sample referral across a range of analyses that are of increasing complexity, data requirement, and time. And so I will flag and we will share the resources to this guide. I also want to highlight that our WHO operational handbook, the latest version, was just published in August. And this includes the steps and processes for implementing a new diagnostic test after selection has been done. In addition, this operational handbook includes information notes. These are available in Annex A. So this is linked on the website. If you search for the operational handbook, the annex links will be there as well. And these are included for the moderate complexity NATs, the low complexity NATs, and targeted next generation sequencing end-to-end solutions, where each note summarizes in just a few pages the recommendations for use from WHO, the key performance conclusions, the test procedure at a glance, the equipment, supplies, and reagents required, the operational considerations for their use, and implementation considerations. Lastly, our operational handbook covers model algorithms, and these have now been combined in this most recent document so that all WRDs, including both molecular tests and lateral flow LAM, are included in this first algorithm. And instead, the decision pathways and the flow for making these determinations and what to do with the different categories of results, which samples to collect and how many samples for which test based on latest guidelines, are now separated up front. So looking towards the future, just as we're talking through new options, these types of approaches and programs specifically understanding their networks is going to be incredibly important because we are seeing continued diversification of the market, new products coming, and different diagnostic strategies becoming available. So evidence is now available on swab-based tests for detection of TB at peripheral levels of the health system. And specifically, these new near point of care tests, as they are classified, can use both sputum swabs as well as tongue swabs. They can be placed at microscopy centers or primary healthcare facilities. They are small battery-operated pairs of devices. And we are also have evidence now available on the pooling of sputa for low complexity automated NAT testing. This is shown on the right-hand side of the slide, where up to 4 samples are processed and pooled, and then the pool is tested. If the pool is positive, the individual samples are re-accessed and they are individually tested, shown with the arrows going up towards the top of the slide, in order to determine which one or more of those sputa is positive. Now, the reason in part that this evidence is being assessed together, because it is undergoing policy assessment now, is because each of these has the potential to decrease program costs while increasing access. And so we look forward to sharing more information. Our public call for data for this assessment closed on July 15th. However, the website is still accessible, and you can find the PICO questions that we're using to guide our assessment, the class criteria definitions, and some of the evidence review data parameters included on that website. In addition, because we recognize that once these tests are selected, new policy is released, we may have this operational guidance that has the algorithms and perhaps some quick overviews. Oftentimes, programs are missing really practical tools and very specific practical guidance for the uptake of new technologies. This could be anything from readiness assessments to job aids or standard operating procedures according to accreditation requirements. And so we are currently working with evidence generators and manufacturers to develop implementation manuals and toolkits across each of these new areas. And I'm just flagging this as these resources would become available if any of these technologies, sample types, or strategies ends up being recommended by WHO after policy assessment that's planned for this November, with policy guidance being released in early 2026 as a target. So just to summarize, to NTB, individuals with the disease must be diagnosed and placed on effective treatment as early as possible. However, there continue to be gaps in services, and so country programs should continue working towards universal access. Recognizing advances in testing technology development and assessment, and that introducing new tests takes time. Optimizing existing networks and the use of existing tools should not be overlooked. And the investment that programs put into understanding their networks now will benefit them in the future for any new technologies that would come along. WRD should be selected and algorithms customized using setting-specific data to ensure that effective strategies are identified early and that increasingly limited resources are optimally used to meet local testing needs. This is inclusive of multi-disease testing and integration opportunities that can increase cost effectiveness in programs and strengthen the health system. So with that, I'd like to thank all of the contributors, ASLM again for the opportunity. And back to you, Lucy.
Thank you so much, Patricia. And I think that those parting words on the fact that investing in diagnostic network assessments or optimizations will really yield for multiple pathogens and not just for TB. So I think it echoes as well what we've been learning, that know your network, know what your challenges are, know what the best tool will be to meet those challenges. So with that, I'm really delighted that we have Puleng Marokane. Puleng is a program manager for the TB molecular program under the National Priority Programs at the National Health Laboratory Services in South Africa, the NHLS. She oversees the large-scale implementation, performance, and quality assurance of TB diagnostic services. So thank you, Puleng, for being here, and over to you.
Thanks, Lucy, for that introduction. And thanks to Dr. Patricia for laying the groundwork for my presentation. So good afternoon, everyone. So I'll be presenting today on behalf of the National Priority Program of the National Health Laboratory Service in South Africa. And I'll be sharing the progress South Africa has made in expanding its TB molecular diagnostics, as well as some of the challenges that come with this implementation. This is just an overview of this presentation. Let me start with some background to frame the South African context in relation to TB. So South Africa has a high burden of TB, HIV co-infection, and drug-resistant TB. If we look at the numbers, the South African population has grown over the years. Despite this, the TB incident rate has dropped significantly. This translates to a change in TB of about 57% between year 2015 and 2023. With that said, challenges still remain in the program. South Africa has a large gap between number of people diagnosed and the estimated TB incidence. The National Department of Health reported around 56,000 people missing in 2023. In those diagnosed, treatment success rates for drug-resistant TB remain an area that needs significant improvement. To give context on the South Africa's National Health Laboratory Service, so NHLS is a parastatal organization that provides pathology services to the Ministry of Health on a fee-for-service basis. NHLS supports around 5,000 healthcare facilities in the public sector, and this is reaching out to about 85% of the population. The facilities include from community clinics up to tertiary and regional hospitals. To support this vast healthcare network, NHLS operates in about 233 laboratories across the country. These labs form a backbone of the diagnostic service, and this is including HIV and TB testing. So this extensive infrastructure demonstrates the scale and the complexity of South Africa's diagnostic services, which is key when considering a multi-platform approach. The NHLS offers a fully integrated service across all pathology disciplines, and this includes forensics. NHLS performs around 114 tests annually. HIV and TB-related diagnostics make up about 20% of all tests. Then HIV viral load and TB NAT are among the top 10 tests by volume. The NHLS TB diagnostic service applies a mix of decentralized and centralized offering. The diagnostic programs include the diagnosis and detection of resistance to RIF with or without the INH. And here we use 3 molecular platforms. Then that's followed by the detection of resistance to fluoroquinolone and isoniazid. And we use the Expect MTB XDR for that testing. Then we have culture and phenotypic DST. We also offer advanced sequencing. The labs are arranged in a tiered format, starting with Tier 1 that offers TB NAT and microscopy, followed by Tier 2, adding culture and XDR testing. Then Tier 3 adds on phenotypic DST and mod PCR. Then lastly, we have Tier 4 that offers the advanced sequencing. This slide illustrates how the South African TB program has diversified its molecular diagnostics from pre-2023 and year 23 onwards. If we look at pre-2023, here we had a single supplier model with 165 laboratories handling all test volume. And the laboratories ranged in terms of volumes from low to very high throughput. And then from 2023, the TB NAT testing was split across several platforms, with 82 sites remaining on the Expect. These were dedicated to low volume testing. And then we had 75 sites that had to transition to the BDMAX. These were dedicated to medium volume testing. And then finally, we have the 8 sites that had to transition to COBAS, and these were dedicated to high volume testing. The drivers for change includes both operational needs of the program and the procurement policies. So just to go through the reasons for diversification. So first of all, the risk of having a single supplier servicing a large program was considered, especially post-COVID-19. around year 2022, where the program started experiencing increase in test demands, and these could not be met by a single supplier. So then this threatened the National TB Recovery Plan, and therefore the diversification was considered. The second reason is that procurement in the NHLS must follow a tender process. So this saw an introduction of competition and alternate suppliers into the market. And the decision after that were also based on WHO recommendations for moderate complexity platforms. So the outcome was that then the tender was split into 3 platforms. Just to go through key steps in the implementation. So the program had to conduct in-country platform evaluations. We had initial engagements with the suppliers, with the NHLS departments like IT and operations. There was engagement with the National Department of Health to guide on the algorithm and the results output. Then we conducted site assessments to assess the structures, the space, benches, network points, power points, air conditioning requirements, storage requirements. We also looked at the waste logistics. For some of the sites, the recommendation was that we move some of the experts to create space for the incoming placements. Then some of the sites, we recommended that they renovate the space to prepare for these installations. The program also had to develop a blueprint for a new test on the laboratory information system. We had discussions with the suppliers, ongoing discussions to discuss the schedules for the delivery of these instruments. And then once the machines were in country, there was commencement of instrument installation. The super user training was also conducted for the NHLS master trainers who had to go back and compile their supplier-specific SOPs. Then discussions around forecasting with the suppliers also happened. We also held ongoing change management sessions in a form of information session. The program also sourced and distributed verification materials to all laboratories. Parallel to this, initial basic training was conducted by the suppliers for all operators. And then the users or the operators had to start verifying the systems together with the interface that was developed, just to make sure that the results were transmitting as per the development. Then based on the verification success and the user competency, the sites had to go live with testing. After go live, training was reinforced internally. The program also ensured that all labs are registered for a PTS scheme. So all labs are registered to participate 3 times a year. Then as data started coming through, monitoring of performance indicators it was initiated. Currently, we're still having ongoing engagements with the suppliers just to ensure that we iron out all the arising issues. For programmatic considerations, if we look at procurement and supply chain management, the challenges and the implemented solutions include the following. So first of all, as highlighted, the risk of having a single supplier servicing a large program was looked at and considered for this diversification. However, I would like to highlight that too many suppliers servicing the same program may also pose other challenges because you are now dealing with 3 different rollouts, 3 different requirements, 3 different workflows, and sometimes 3 different challenges happening all at the same time. Also, because the tender process looks at pricing, it's important to note that the cheaper the assay does not always mean it's the way to go. So cheaper assays may require additional resources with more complex workflows. And the more complex the workflows, that may increase turnaround time and impact patient care. So in our case, we had to streamline workflows. For example, on the BDMX, we used an interleaving function on the instrument This allows us to load a second run while the first run is undergoing amplification. So turnaround time has progressively improved across the moderate complexity platforms as the program matured and also as the users became more comfortable with the newer technologies. Very important also is to make provision for budget for the indirect implementation cost that can come with this implementation. So these may include renovation to accommodate larger instruments, procurement of wider benches for the BDMX, for example. The standard bench that we had in most laboratories was not working, so we needed to either extend it or procure a new bench. We may need to increase refrigeration capacity. This specifically applies to cobas that has reagents that needs to go into the fridge. And then the interface developments, IT-related costs, all those need to be catered for as indirect costs. Then in terms of forecast, we need to work with the suppliers and have an understanding of their manufacturing lead time. So in our case, we insisted on in-country reserve of buffer stock to accommodate any testing surges. Also, it's important to plan around the phasing out of stock for the outgoing supplier. In our case, we were also not able to distribute the stock because the stock is purchased under different business regions. So the labs had to complete testing on the stock that they had in place before they can transition to the new platform. Relationship between the customer and the suppliers, also very important to ensure successful implementation. So here we had to define roles and responsibilities and define escalation pathways. So in our case, we regularize meetings between the implementer and the suppliers. We also had a service level agreement established. This was to determine and agree on performance indicators. In terms of implementation, remote access for the program can be very useful. So even though in our case, this is still ongoing developments on both platforms, but once ready, we will have to ensure compatibility of these systems to our network and LIMS. And also, we need to look at the assay testing parameters to ensure that we can access as much information as possible. And for the proficiency testing, very important to consider that there is differences in limits of detections between these platforms. There's also differences in target detection between the assays. There's variation on how MTB is detected and also on how the non-wild type sequence is detected. So not all assays are also reporting INH susceptibility. So it's important to consider all these factors when determining the compatibility of your proficiency testing schemes. For the national TB algorithm, in our case, this required a revision because the previous version of the algorithm was supplier-centric to the expect. So the decision was that we were going to change that in the algorithm and refer to all tests as TB nudge. So therefore, the algorithm was revised and then dissemination was done through training. In terms of pre-analytic consideration, very important to consider that there's variation in the pre-analytical specimen processing. There's a variation and differences in the duration of the processing. There's different processing reagent between suppliers, and also depending on the supplier, you may have more than one reagent type kit required for the pre-processing. The reagent type kits also differ in quantities of components. So here we needed to work with the suppliers to have a reagent calculator available for the user so that it can assist them in the ordering and determining how much stock they need in the laboratory. Also to consider that there's different reagent storage requirements between the platforms. So we're going to need fridge to store some of the reagents. There's different workflows between the assays. So all these challenges will have to be addressed through training and workflow assessment. We have to ensure that the SOPs cover those details. And then for analytic consideration, not all systems are fully closed or completely closed. So with the expect, you'll remember the process specimen is loaded into a contained cartridge with subsequent testing steps happening within that cartridge. So this differs for cobas and BDMAX. And therefore, this saw an introduction of environmental controls into the workflow. There's also increased wastage generation, so we need to adapt the existing waste logistics to accommodate this increase in waste, including provision for liquid waste on the covers. There's variation in platform complexity. There's also lack of full automation in some of the areas. So for example, on the covers, we still need to sort samples for susceptibility testing. So after an MTB run, you need to take out all your positive samples and load them on the next run for riffin INH detection. There's variation in target detection between the assays. Here, an example that I can give is BDMAX does indicate mutations to the KETG gene, so which is very useful information for the program, and therefore that was included in the final reporting. So it's important that we have engagement with the suppliers to better understand the algorithm logic around defining MTB detection and resistant calls. Then I also want to highlight that there is a possibility that we can have discrepant results between assays. This will happen where the same patient or client may have been tested using a different assay at different time points. So meaning we need to really emphasize that post-implementation monitoring so that we can identify all these performance indicators and have a way of dealing with them. There's also unique results categories per assay. So you will remember on the expect we have MTB trace results reported, and on the BDMAX we have MTB low pos. So the programs will need to see if there's a way to standardize the message for the clinician so that we can guide more direct clinical management. Sensitivity to the environmental temperatures also need to be considered. On the BDMAX, we started experiencing PCR heater warnings. So this meant that we needed to apply a stricter environmental temperature monitoring. In other labs, we had to recommend procurement of additional air conditioning to control the laboratory temperatures. Then again, recommendations for moderate complexity platforms from WHO excluded testing of extrapulmonary specimens. So for us, this means that at cobas and BDMAX laboratories, we have to retain some of the expect platforms to specifically conduct testing for EPTB samples. So this meant that those laboratories will now have two different or separate workflows. And you can imagine that can create further complications. Then in general, increased sensitivity for detection of these TB net assays means that we really need to maintain GLP to avoid contamination. So we need to make sure that there's strict adherence to the SOP and that we monitor these performance indicators, even using our PTS schemes. Finally, for post-analytic consideration, the results reporting between these three platforms is different. So expect only provide rifampicin only. BDMAX and cobas provides both RIF and INH. So the implemented solution is that where RIF resistant is detected, irrespective of the TB NAT used, then will require further centralized testing on the second sample. And this will be done on expect XDR and TB culture. Then on that note, also to highlight that the Expect MTB XDR cartridge has a higher sensitivity for isoniazid resistant detection. And this is due to the inclusion of 2 additional genes. So that fact also means there could be possible discordance between the first line assay and the Expect XDR cartridge. A standardized approach was then adopted since isoniazid is not reported by all assays. So the decision was that we were going to suppress isoniazid susceptible results and not release them, and only release isoniazid where resistance is detected. So in conclusion, diversification of TB net testing in South Africa required specific consideration and implementation strategies. Diversification may not always be applicable in certain settings. It's important for programs to consider the potential impact of increased algorithm complexity when you add more than one platform or when you're changing. Programmatic transitions do take time, as Dr. Patricia has highlighted. So ours took around 19 months. So they do take time, so we need to be patient if we consider to go that route. And then we need to consider the suitability of the supplier's workflow to our settings, our infrastructure, and individual labs. And then finally, each setting is unique and may require adaptations for what is best suited. I would like to acknowledge the following teams and organizations on my slide, and thank you very much for listening.
Oh, Puleng, that was really a brilliant presentation and really showing the complexity of the system that you have implemented in South Africa, and highlighting again that this is a long process and that requires countries to be able to know their network. So I think I just want to start, and we have quite a number of questions in the chat, and I want to start off on something you mentioned on the unique result categories that you have across the different platforms. So when you were doing your validations, did you, for example, see if there was any difference between what expert would call trace or what BDMAX, for example, would then refer to as low positive? Were there any differences, and might it be better if the lab has a standard format for those results to avoid the confusion for clinicians? Over.
Thank you very much for your questions. So I don't have the validation data with me, but yes, there is a difference in the limit of detection. So trace on the expect is the lowest detectable result, and then MTB low pos on the BDMAX also their lowest detectable result. So there is some difference in the limit of detection between the two assays. But with that said, we did consider that even on the implementation, because they do meet the WHO minimum performance standard. So again, as mentioned during the presentation, we had to find a way to standardize the message to the clinicians. And this took a lot of work analyzing the data to determine what message, because we don't want to say to some clinician groups that this is an MTB trace, and then we come back and communicate MTB low pos. So we had to look at CT values to come to an agreement that we are going to label this type of result as MTB trace, for example, and not send out 2 separate messages.
That's great. Thank you so much. And so another comment. Yes, go ahead, Dr. Pedro.
Sure, Lucy. Maybe just to add to Puleng, I think to simplify things and standardize, Puleng mentioned interfaces. And so depending on the result category that's generated from the instrument, there are interfaces which convert results to a particular format. So a trace is not released as a trace, depending on the age and specimen type, etc. It may be converted to a MTB detected, obviously without a rifampicin or isoniazid, without a rifampicin result. And the same and similar interfaces define how a low positive is actually reported. And this also helps guide clinicians and what rules trigger when within the interfaces and the LIMS is based on data and expert consensus. So that also helps guide the clinical management.
Yeah. That's great. Thank you so much. So a follow-up question to that is, I mean, the South African system is beautiful in the way how you've diversified your systems, but in one way that can also be looked at as if you are centralizing TB testing, and there's a focus right now to decentralize testing, to bring testing to the lowest level where the patient is. So have you done any analysis to see how that impacts the pre-treatment loss to follow-up, for example, and if you know how having these multiple systems has actually improved time to treatment initiation, for example, but also have you done any of those trade-offs to see are you having more patients having a delayed diagnosis or being lost prior to a diagnosis being made as testing has sort of moved up from where the patient is seen? Over.
Sure.
Okay, so I just wanted to say, so the initial EXPECT program back in year 2011 followed an original blueprint for smear microscopy. So smear microscopy laid the foundation for the placement of the TB-NAT platform. So that was EXPECT at that time. So for this diversification project, placement was decided based on the same blueprint. So there was no further centralization of the program. Yeah, Dr. Pedro, you can add.
Sure. So exactly the point that even though there are platforms that are only conducive to centralized testing, these platforms were just placed at very high throughput laboratories. But the footprint actually remained the same. The program is highly decentralized, and a platform like COBIS really can only be placed in certain laboratories due to its size. So this was the considerations. But the extent of the decentralization, and really in certain geographic areas, we're really testing at near point of care based on how decentralized the program is. And so where you, in essence, by diversifying, you created a range of different platform sizes, which could then accommodate very high throughput testing versus right down to the smallest near point of care laboratories. So in a sense, it is not really centralized. The extensive decentralized footprint remained after diversification. Then in terms of impact, so this is linked to another question in terms of turnaround time. So there are turnaround time targets that are defined between the NHLS and the ministry, particularly for the initial testing on TB-NAT, and that's around 95% of tests available within 40 hours. And that is the target. It doesn't really matter what the platform is. So even with the higher throughput platforms, you just need to ensure that we placed more than one platform at a particular lab to ensure that you have the throughput so that you can still meet the turnaround time. So on that basis, there shouldn't really be an impact on patient care, because you're still generating the required results within the agreed turnaround time. So it wasn't smooth sailing, though. Remember, the program had already been established on a single supplier for more than a decade. And so changing perceptions and also getting operators used to the new workflows in itself had challenges. But eventually, with time, as the program has settled, turnaround time now is far more efficient and is approaching the targets that were originally set. But that was expected in making such a big transition.
That's great, and I think because you touched around point of care, Patricia, one of the questions that came up a few weeks ago with these discussions on near point of care testing is, why is WHO calling them near point of care, not just point of care tests? Because you've nicely laid out in your presentation, you have this guidance on medium complexity NATs, LC NATs, and now we're going to have near point of care tests, which ideally will be where the patient comes. So why not just call them point of care? Over.
Yeah, it's a great question. And for those that are interested in learning more about these definitions and the very specific characteristics that separate the classes, those definitions are in our target product profile document that was published in 2024. What I will say is that compared to the low complexity, the near point of care technologies that we're looking at remain instrument-based, and they still have reagents that are fully enclosed, but they still also require multiple steps with 2 instruments. And so I think it's important to understand that qualification, because we're not talking about a lateral flow urine-based test, for example. That's what we classify as a true point of care assay. That's an assay that can be done by a healthcare worker without any specific training. At the bedside, it provides a result very quickly. It's a one step, essentially. You add the urine after sample processing. And so I think that's a very different profile than what we're considering with these small instruments. Now, they all are small and they are more robust. So the instruments do have higher temperature requirements that they can be in. They have fewer dust requirements. They are more robust around movement. So they have been assessed in active case finding, for example, circumstances. And they are battery or UPS operated. However, those batteries need to be recharged occasionally in order to use them as well. And so we just aren't yet to a place of having true point of care instrument-free tests that have these characteristics for both people who are HIV negative and positive.
Thank you. And we started this conversation by talking of integration. So I'm just wondering, Pulang, on the Roche or the BD Max, have you been able to do any integrated testing apart TB and HIV or other pathogen, or are these just strictly for TB? And is there a plan to do any integrated testing? Over.
Yeah, so currently the focus is stabilizing the existing platforms. So yeah, we don't know whether other testing will be considered in future. But I think the focus now is to do TB only and make sure the programs are stable. Then we will look at other option maybe later on, if possible.
Yep, and to add, so we do consider multi-disease testing, and some of the same kind of platforms are used in other disease programs. One of the challenges that we have is that in terms of scope of practice within the regulatory body, only a defined pathology discipline can operate a specific test. And so that then becomes a hurdle to full integration and multi-disease testing. But you can certainly include as long as additional tests fall within the scope of that pathology discipline. Thanks, Lucy.
All right. Yep. No, that makes sense. And I think as we approach the hour, someone has just asked, could you please share a breakup of the number of tests that are done annually on each of these tests, on each of these platforms? Sorry, I don't know if you have that data or a figure.
So we can,
yes,
yeah,
Dr. Petro, go ahead.
We can just provide a overall. So the platforms with the highest capacity would be the COBIS platforms, but currently the way the tender was awarded, the majority of testing is actually assigned to the BD platform. Cepheid is actually conducting the least of the share, and in second place would be the Roche.
All right.
And obviously
Yeah,
we have to factor in, yes, all the extrapulmonary TB would also, fall under the Cepheid's platform.
yeah. All right. Thank you so much. This was really an exciting discussion. So I'll just ask Patricia if you can give a few thoughts on what does the future of TB testing look like, and Puleng, you can give your parting remarks on what makes a successful tiered network. Over.
Sure. I think the future looks further diversified for TB. I mean, I think we will have more options in tiered networks with different capabilities. And I think that's a really good thing for patients and programs. I do think that this session and Puleng's nice presentation have highlighted some of the considerations around that and expectation setting, the importance of data and strategic planning. But I do think that we see in the pipeline more of these assays, and we're seeing more programs have an appetite to take up different technologies, to have that market diversification and support in their countries, but also to multi-disease test and to work towards integration outside of TB alone. I think there are a lot of opportunities, and Pedro nicely used the word hurdle. I think this classification of people, but hurdles are there to be leapt. And I think that we will continue to leap the hurdles that are in place in some of the health systems that have been historically there, particularly due to siloed funding opportunities, that will allow us to work more holistically towards service provision.
Okay, thanks. So I think from my side, I can say if programs do decide to diversify, then it's important that we establish clear and proactive communications right in the beginning, especially for the users. So in our case, the information sessions help a lot to keep everybody updated with the developments and also to manage expectations and minimize panic. And then secondly, the programs may need to standardize some of the reporting to avoid downstream confusion, especially if you have more than one platform in place. So you will need to look at the messaging that you send out to the clients. Finally, it's not a one size fits all. So South Africa is still learning from this experience. But we can say that programs must anticipate unique local challenges, and therefore they must build in some flexibility into these implementation plans. Thank you very much.
Thank you so much, Puleng. Dr. Pedro, I don't know if you want to say something.
Nothing further. Puleng summarized. Thank you.
Thank you so much. And thank you everyone for attending this brilliant presentation. And again, thank you so much to our speakers for making the time and sharing your expertise with all of us. So thank you everyone, and see you at our next ECHO session. Goodbye.